Thyroiditis is a group of inflammatory thyroid disorder in which acute, subacute, or chronic thyroid disorders are there. These are very compulsory to differentiate between surgical cases and non-surgical cases. Thyroiditis mainly divided into two categories according to the pain and tenderness in the neck. If pain are there, there is three categories: subacute granulomatous thyroiditis, infectious thyroiditis, radioiodine induced thyroiditis. If pain is not there, then subacute lymphocytic thyroiditis, chronic lymphocytic thyroiditis, fibrous thyroiditis, and amiodarone induced thyroiditis. Some subcategories are there in like subacute granulomatous thyroiditis. There is decurvent giant cell thyroiditis there. Subacute lymphocytic thyroiditis or silent thyroiditis. There is postpartum thyroiditis and drug-induced thyroiditis is there. In chronic lymphocytic thyroiditis, there is Hashimoto thyroiditis and postpartum thyroiditis there. These are the subcategories. If you do radioiodine uptake test, there will be increased radioiodine uptake in mainly two diseases like microbial inflammatory thyroiditis, mainly microbial infection like Staphylococcus aureus thyroiditis. There is increased radioiodine uptake. Another is in the Graves' disease, but Graves' disease is not a subtype of the thyroiditis. And rest disease showing the decreased radioiodine uptake like subacute granulomatous thyroiditis and chronic lymphocytic thyroiditis. These shows decreased uptake during radioiodine uptake. So these category mainly radioiodine uptake increase in the microbial or Staphylococcus aureus thyroiditis. Now we will talk about first disease, that is decurvent or giant cell or subacute thyroiditis is an uncommon cause of transient thyrotoxicosis. The typical patient present is female between 40 to 60 years of age. Presentation is with the pain in the neck, often associated with the swelling. And there are systemic presentation like fever, dysphagia, and malaise is also there. The pain is striking feature may radiate to the ear and worsen during the turning of the head. On examination, there is often swelling of the either thyroid lobe, which may extremely painful to palpate. Sign of thyrotoxicosis may be present, such as tachycardia, tremor, irritability. There may also be fever, and it takes 8 weeks for the pain to resolve and complete resolution seen in 6 months. Laboratory shows there is increased ESR and CRP level is also there. And thyroid scintigraphy shows complete absence of the uptake. Histologically, there is characteristically multinucleated giant cell in the central core of the colloid. Initial TFT shows thyrotoxicosis with suppressed TSH level and elevated T4 level. This reflects destruction of thyroid follicles by the inflammatory process and release of preformed thyroid hormone in the circulation. Clinical course of disease. At 12 to 16 weeks, there may be hypothyroid phase during which damaged tissue is unable to generate thyroid hormone. Most patients do not require treatment with thyroxine and most are ultimately euthyroid. Rarely, hypothyroidism may be permanent. Initial thyroid autoantibody may be present in some cases, although these are transient and retain thyroid autoimmunity for the life. The course of the subacute thyroiditis is like there will be increased level of the TSH initially shows hypothyroidism, then there is plateau and there is decrease in the TSH level. So hypothyroid stage is there, then euthyroid, then ultimately hyperthyroid stage is also there. So complete course is about 12 to 16 weeks of this disease, which is completely resolved by itself. The causes of this decurvent thyroiditis may be mumps virus, coxsackie virus, influenza virus, and adenovirus may be there. Treatment is mainly supportive. Non-steroidal anti-inflammatory drugs like endomethacin, aspirin is given. Sometimes required beta blocker for the hyperthyroidism stage. And if symptoms are not resolving, then you can give prednisolone in tapering doses. So this is the treatment of the decurrence giant cell subacute thyroiditis. Second is infectious or microbial inflammatory thyroiditis. This microbial inflammatory thyroiditis is also known as acute suppurative thyroiditis. This is a rare subtype, most often caused by presence of gram-positive bacteria in the thyroid gland. Staphylococcus aureus is the most common infectious agent, but other organisms may be like pseudomonas may be present. This disorder is rare because of inherent resistance of the thyroid gland to fight with the infection. Microbial inflammatory thyroiditis often occur between women 20 to 40 years of age. Most patients have pre-existing thyroid goiter. So, in goiter cases, this microbial inflammatory thyroiditis is more common. Clinically, there is fever, pharyngitis, pain on swallowing, and that pain may radiate locally. Sometimes tachycardia is also present and elevated ESR also there. So treatment is culture induced antibiotic therapy. Third category is invasive fibrous thyroiditis or Riedl's thyroiditis. First discovered by Riedel in 1898. This remains the rarest type of the thyroiditis. In addition to the development of dense fibrosis of thyroid gland itself, extracervical site of fibrosis can occur like inflammatory fibrosclerotic process including sclerosing cholangitis, retroperitoneal fibrosis and orbital pseudotumor. Mostly it's common in women between 40 to 60 years of age. Symptom may be like dyspnea, dysphagia and stridor is also there. There is stony hard, mostly unilateral swelling is there. There is decrease in radioiodine uptake and elevated ESR is there. Thyroid autoantibodies are present in about half of the cases and there is only symptomatic treatment is required like steroid and sometimes surgical based resection of thyroid isthmus if there is pressure symptom is required. There is gross fibrosis in the histopathology and the thyroid gland is there. Fourth is radiation induced thyroiditis. Administration of large dosage of radioiodine may result within 2 weeks in thyroiditis. There is usually a requirement only for simple analgesia and condition tend to be resolved within 2 weeks of the onset. Significant pain or swelling may necessitate use of oral glucocorticoid therapy, steroid therapy. Fifth is iodine-induced thyrotoxicosis. Iodine-induced thyrotoxicosis result from genetic changes that lead to autonomous development of the thyroid hormone within the thyrocytes, which increase production of the thyroid hormones. This jode-based effect is often seen in patients with toxic multinodular goiter in the area of iodine deficiency. It may also occur in absence of pre-existing disease, and this condition usually resolve within 6 months. Iodine-containing contrast sometimes may lead to iodine-induced thyrotoxicosis in about 0.3% of cases. Sixth is the silent painless thyroiditis or subacute lymphocytic thyroiditis. Painless thyroiditis can occur in early stage of autoimmune thyroiditis. This may lead to mild biochemical changes like hyperthyroidism without increase in inflammation in the thyroid gland. And there is painless enlargement of the thyroid gland in about 50% of cases. There are Hashimoto disease-like changes and which include extensive lymphocytic infiltrate with the plasma cell without the multinucleated giant cells in the histopathology. The duration of thyrotoxic phase is about 8 weeks. Symptomatic treatment with beta adrenergic blocker sometime required. Then there is hypothyroid phase that may last up to 6 months. In most patients, euthyroidism is eventually restored, but permanent hypothyroidism is almost certain to develop over long time, and it will develop about after 5 to 10 years of duration. Seventh is amiodarone induced thyrotoxicosis. Use of amiodarone may result in thyrotoxicity by two ways. First, if there is pre-existing thyroid disease there, if you give high dose of amiodarone, that may induce thyrotoxicosis because of iodine content. This is termed as iodine-induced thyrotoxicosis type 1. In type 2, when there is primary destruction of thyroid gland because of the cytotoxic effect of the amiodarone and its metabolite, which lead to the increase in the hormone level, which is known as thyroid amiodarone-induced thyrotoxicosis type 2. Treatment is simply withdrawal of the drug and sometimes required antithyroid medications.